Hello, dear aspirants. Welcome you all to Master Nursing classes. So as all of you know that we are discussing the very important questions for our RRB Nursing Superintendent and Norcet 8 exams. So here we are only not discussing the questions. We are dealing with the concept. So those concepts that will definitely help you in our upcoming RRB Nursing Superintendent exams. Okay. So yes, students are welcoming you all. Yes, very good morning, and very good morning. Yes, namaste, very good morning. Welcome you all to the Master Nursing classes. Yes. So here we are not only dealing the questions, we are dealing the concept. Okay, in a given period of the time. So I am making the time to make it worthy. Okay. So students always remember that yes, the number of the hours you will be studying is not going to matter in the exams. So in that particular hour, how much content you are covering, how much new things you are learning, how much the things you are revising, so that is going to be mattering in the exams. Okay, so that is what the main motive of the master nursing classes. Okay, so use that particular 1 hour to be completely subject worthy. Okay, so that will completely knowledge worthy. Yes, so in this particular 1 hour you will be gaining a knowledge that is very much required for your upcoming exams. Okay, so not only discussing the questions, we are discussing the concept that will definitely helps you to eliminate the option, that will definitely helps you to include the options and give the correct answer. Okay, so yes, so the master nursing classes will make changes in your result. Okay, the master nursing classes will brings you to out of the crowd, and it will make you be as a rank students. Okay, yes, do follow to the channel. So if anyone is new to the channel, and yes, if anyone is new to the MNC family, so the link is there in the description box for our Telegram group, where we are discussing the updated things, where we are always keep on putting the questions that will helps you all students. Okay, so if anyone is new, so do join to the channels. The link is there in the description box. Okay, okay, so without wasting the time, so we will start the today's class, students. Here is the first question of the today's class. So do read the question completely, carefully, and try to give the best answer in the comment box. Okay, yes. Here is the question. Yes, do read the question properly. Okay. Yes, it is the most important question, students. So, how many pairs of the spinal nerves? How many pairs of the spinal nerves are there in the human body? So, option A is telling that it is a 12 pairs. Option B is 24 pairs. Option C is 31 pairs. And option D is the 33 pairs. Yes, students, what is the answer? So, how many pairs of the spinal nerves are there in the human body? Yes, can anyone able to answer in the comment box? Very beautiful. Yes, yes, very nice, very nice. Yes, students. So that is the yes. Almost all of you have given the correct answer. 31 pair is the correct answer. So number of the spinal nerves are there in the human body are the 31 pair. So how do you remember? Okay, right. 1, 2, 3, and 1. Okay. So 1, 2 are the number of the cranial nerves. Okay. So these are the cranial nerves, and 3, 1 is the yes the number of the spinal nerves. Yes, the so 12 pairs of the cranial nerves we are having, and yes, in other hands, so we are having the 31 pair of the spinal nerves. Okay, is that clear, bacho? The mnemonic works in the exams. The mnemonic works in the exams. Okay, yes, is that clear? So my question is, how many cervical nerves are there in the human body? Okay, so yes, in the spinal nerves, we are dividing the 31 pairs of the spinal nerves. So my question is, what are the 31 pairs of the spinal nerves? Okay, so yes, remember, students, that is the spinal nerves. Spinal nerves are yes. How many pairs of the cervical nerves are there? Yes, cervical nerves are the not 7 students. 7 are the cervical vertebrae. Okay, so yes, the eight cervical nerves are there. Then come to thoracic nerves. Yes, how many pairs of the thoracic nerves we are having? Yes, remember there is the eight cervical nerves, and seven yes cervical vertebrae. How many vertebrae bones are there in the cervical means that is the 7 will be your answer. Okay, yes, and how many cervical nerves means 8 will be our answer. So 8 cervical nerves we are having. Then yes, very nice. 12 thoracic nerves. Then come to the lumbar. Yes, how many lumbar nerves we are having? So lumbar will be the 5 lumbar nerves. Then yes, that is the sacral. How many sacral nerves we are having? Again, the 5 will be our sacral nerves. Then come to the coccyx. Okay, so how many coccygeal nerves we are having? One coccygeal nerves we are having. So total how many? Yes, 8 plus 12, that is the 20. 5 plus 5, that is the 10 plus 1. Okay, 20 plus 10 plus 1 is the your 31 pair of the yes spinal nerves. Okay, then total number of the cranial nerves we are having is the 12 pair. Okay, then total number of the spinal nerves we are having is the yes, that is the 31 pair. Okay, so my question is, how many pairs of the rib is there in our human body? So how many pairs of the rib? Yes, can anyone able to answer for this one? Yes, how many pairs of the ribs? So ribs are the bones of the our thoracic cage, which is protecting our, yes, our lungs. Okay, so ribs are the which type of the bones? Ribs are the, is that long bones, short bones, or which type of the bone? Yes, students. So can anyone able to answer? First answer, how many pairs of the rib? Second question is, ribs are the which type of the bones? Yes. So yes, 12 pairs of the ribs we are having again. Okay. So how many pairs of the rib we are having again? 12 pairs of the rib. Remember, 12 pairs of the cranial nerve, 12 pairs of the rib. Okay. The length of the rectum is 12 centimeter. Okay. The length of the rectum is the 12 centimeter. Okay. Yes. Again, the length of the fallopian tube is the 10 to 12 centimeter. Okay. Yes. Revise with me. How many ribs we are having? 12 pairs. How many cranial nerves we are having? 12 pairs. Length of the rectum is 12 centimeter. Okay, so length of the rectum is 12 centimeter. Length of the fallopian tube is the 10 to 12 centimeter. Clear bachcho? So how many questions? 4 questions. How many answer? Single answer, that is the 12. Okay, that is the 12. Okay, is that clear bachcho? Yes. Yes, clear. Then how much the pregnant mother will gain the weight in the pregnancy? Again the answer will be the 10 to 12 kg. Okay, yes. How much weight the pregnant mother will gain during the period of the pregnancy? That is the 10 to 12 kg. Bacho, clear? Clear? Yes. So this is the specialty of the master nursing classes. Okay, yes. So how many ribs we are having? 12 pairs. So my next question is, yes, how many true ribs, how many false ribs, and how many floating ribs? Bacho, remember that one, this one. So this they will ask in depth in the on AIMS Norcet, but for RRB it is more than sufficient. How many ribs? That is the 12 pairs. But for the AIMS you have to remember. So this is our GP sternum. Okay, so this is our complete sternum. This is a Gifford process. Okay, yes, this is the sternum. Okay, so we are having the 12 pairs of the ribs. Okay, so first 7 pairs are the true ribs. Okay, 1, 2, 3, 4, 5, 6, and 7 are the true ribs. Okay, so why we call this, these are true ribs? Because these ribs directly joins anteriorly to the our sternum and posteriorly to the, yes, to the spinal. Okay, so posteriorly to the vertebral column. Okay, so these first pairs of the 7 ribs we call as in the true ribs. Okay, so first 7 pairs of the ribs are the true ribs. Okay, clear bachcho? So then how many of the false ribs we are having? So that is the three pairs. Okay, so why we call the those are the false ribs? Why? Because it will be not direct contact with the our sternum. Okay, so it will be contacted with the cartilage of the, yes, cartilage of the our like we can say the ribs. Okay, so this is what we call, yes, the false ribs. How many pairs of the false rib we are having? 3 pairs of the false rib. Okay, again the floating ribs are the 2 pairs. Okay, the floating ribs are the 2 pairs. So 2 pairs of floating rib. Why we call this one as in the floating? What is the meaning of the floating? Floating andre ಏನು? Floating andre ಹಾರಾಡೋದು. So floating is free. Okay, that is the floating. Means this last 2 pairs of the rib means the 11th and 12th pair of the rib, 11th and 12th pair. So that is the last 2 pairs of the rib are not connected to any kind of the structures anteriorly. So these ribs are freely floating. So these floating ribs are these 2 last ribs are called as the floating ribs. Okay, so then, yes, the 8th, ninth, and 10th pair of the rib. So these ribs are the not directly contact with the sternum. So these ribs are called as the false rib. Okay, these ribs are called as the false ribs. Okay, so these first 7 pair of the ribs. Okay, so these are directly connected with the anteriorly to the sternum, posteriorly to the vertebral column. So we call this one as the, yes, the 7th pair of the true ribs. Clear, bachcho? Yes. So total how many pairs? 7 pair plus 3 pairs, 10 pair plus 2 pair. That is the 12 pairs. Okay, clear, bachcho? Yes. So do thumbs up here. Clear? Yes. 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 So that is what you have to compare and study. Okay, you have to compare and study. Okay, is that clear, bachcho? Yes. Total 12 pairs of the ribs. Among those, 7 pair are the true ribs, 3 pairs are the false rib. Okay, last 2 pairs are the, yes, that is the floating ribs. Okay, the question against they will ask like, so what all are the, yes, three false rib. Okay, that is the 8th, 9th, and 10th are the false rib. 11th, 12th are the, okay, floating ribs, and first 7 pair are the, yes, our true ribs. Clear, bachcho? Clear. Very nice of you all. Okay, so again, the answer for this question will be the option C, that is the 31 pair of the spinal nerves we are having, and 12 pair of the cranial nerves we are having. Okay. Yes. So spinal nerves are the, again, there are sensory nerve and motor nerves we are having. Yes. What is the sensory nerve? What is the motor nerve? What is the sensory nerve and what is the motor nerve? What is the apparent nerve? What is the apparent nerve? Okay. So yes, this is our beautiful brain. This is the spinal cord. Okay, so this is the your hand you consider. So if anything like a burn happened to your hands, here we are having the nociceptors. Okay, what are the nociceptors? Nociceptors, your pain receptors. Okay, pain receptors. Okay, so it will take the pain, okay, to the sensory nerve. Okay, to the sensory nerve. Okay, from here the sensory nerve will originates. Okay, so it will go to the brain. It will go to the brain. So it is going upward. So it is going upward. So we call this one as in the apparent nerve. We call this one as in the apparent nerve. Okay, so it will tell to the brain the pain is happening. Okay, so the brain will send the one more signals. Okay, from brain to, yes, the periphery, from center to periphery. So this is what we call as in the apparent nerve. Okay, this is what we call as in the apparent nerve. Okay, so yes, the signals coming from the brain to periphery or from the center to periphery, we call that as in the nerve that is called as in the efferent nerve. Okay, the pain signals which is carrying from the periphery towards the center. So this is what we call as in the apparent nerve. Okay, so this is what we call as in the apparent nerve. How you can remember? So already I have told the mnemonic previously. Okay, that is the same. Okay, how you will write the same? SAME. Okay, sensory nerve is the apparent nerve, motor nerve is the apparent nerve. Okay, so yes, from the sensor center to the periphery it is coming, and it is telling, yes, the burn is happening, take your hand back. Okay, you are doing the movement, that is what we call the motor movement. Okay, so that's what we call as the motor movement. The apparent nerve will do the motor movement, and yes, the apparent nerve will carry the sensory signals. Is that clear, bachcho? Clear? Yes, very nice of you all. Okay, so this is what, yes, the spinal nerves, how it will works actually. Okay, clear? So then the next question is, I hope in one question we have studied the nearly 20 questions. Okay, this is the specialty of the master nursing classes. Okay, so here is the next class. Sorry, here is the next question. Let's do read the question properly, perfectly. So then we will go for the answers. So this is also most important question. Okay, important questions means like the students will get confused for easily. Okay, so that comparison and study will make you a champion in the exam. Okay, yes. So the question is, yes, what is the term used for rupture of the fetal membrane, okay, before the onset of the labor? Okay, so the rupture of the fetal membrane before the onset of the labor. So what is the term we have to use? Option A is telling that it is a preterm premature rupture of the membrane, PPROM. Then option B is telling that it is a premature rupture of the membrane, that is the PROM. Okay, that is the PROM. Then option C is that term rupture of the membrane. Then option D is that artificial rupture of the membrane. So these are the very, very and very important, okay, words you have to differentiate and study, okay, to get the better rank. Students, first you have to know what is the rupture of the membrane. Okay, so this is the uterus. In the uterus, okay, so there are, I told already, this is the placenta and this is the fetus. Okay, so here it is the two layers of the membranes are there, that is what we call the fetal membranes. Okay, so what is the outer fetal membrane? That is the, yes, outer fetal membrane is the chorion, and inner fetal membrane is the amnion. Okay, so inside this cavity we are having the fluid, that is what we call as in the amniotic fluid. Okay, this is what we call in the amniotic fluid. And yes, the structure which is connecting the fetus to the placenta, this is what we call as the umbilical cord. Okay, so this membrane, what you call these two membranes, that is the fetal membrane. Okay, so outer is the chorionic layer, inner is the amniotic layer. Okay, so two fetal membranes we are having. So this is what we call the cervix. in the first stage of the labor, this cervix become fully dilate. Okay, this cervix become fully dilate. Okay, so when the cervix become full dilate, this membrane will rupture automatically. Okay, this membrane will rupture automatically. So then the amniotic fluid will comes out. Okay, then the fetus will comes out. So this is what we call as the rupture of the membrane. What I told, the membrane, it should be ruptured after the full dilation of the cervix. Okay, full dilation of the cervix occurs at the end of the first stage of the labor. Okay, so the first stage of the labor begins with the, okay, true labor pain. Okay, so true labor pain then ends with the full dilation of cervix. Okay, so this is what we studied in the first stage of the labor. First stage of the labor begins with the true labor pain and end with the full dilation of the cervix. Okay, whenever there is a full dilation of the cervix, that same point the rupture of the membrane should happen. So inside the rupture of the membrane, where there is a prostaglandin is there. Okay, this prostaglandin F2, which prostaglandin is there in the membrane. There is a prostaglandin F2 is there in the fetal membrane. Okay, when the fetal membrane ruptures, so this prostaglandin makes the pain and contraction. Okay, by stimulating the oxytocin. Okay, is that clear? Bacho, clear? Very nice. Okay, so this membrane, what in case if it is damaging or which is rupturing before the first stage of the labor? What I told, the membrane should rupture at the end of the first stage of the labor. Okay, so what happens if it is damaging, okay, or the membrane is rupturing? Okay, so that is before the onset of the labor. So labor is didn't yet onset. So okay, so didn't yet started, labor didn't yet started, but the membrane got ruptured. So what we call this one? Yes, simple students, there are the two words you have to remember here. So that is, let me take a new slide so you will be clearing. Okay, so rupture of the membrane, you have to know that if the membrane is rupturing before 36 week, before 36 week plus before onset of labor. Okay, before onset of the labor, if the membrane is rupturing means, so before 36 weeks and before onset of labor. So before 36 week means we call this one as in the preterm. Okay, then before onset of the labor means we call this one as in the premature. Okay, so membrane is rupturing, that is called as a rupture of membrane. Okay, yes, so if the membrane is rupturing before 36 week of the gestation and before the onset of the labor, so that is what we call the preterm premature rupture of membrane. Okay, so if in case the membrane is rupturing, okay, so before onset of the labor, before onset of labor, okay, but after 36 week, after 36 weeks means, so the 36 week is completed. So after 36 week, it may be a 37 week, it may be a 38 week, it may be a 39 week. Okay, so we call this one as in the term. Okay, so term means, so no need to write it is a term rupture of the membrane. You have to just need to write that is the, yes, it is before onset of the labor, we can say that is a premature rupture of membrane. Okay, so this is the just PROM. So PROM means, yes, the membrane will get rupture before the onset of the labor, but after 36 weeks. But in PPROM, yes, the membrane will get rupture before the onset of the labor and yes, before the 36 weeks. So this is very, very, very important. The word before and after changing your answer in the exams. Okay, yes, you have to consider after 36 weeks, that is the PROM. Yes, before 36 weeks, that is the PPROM. Okay, so this is the, yes, this is the rank deciding word we have to decide. Okay, you have to consider in your mind while solving this question. Okay, yes, in the question what they have given, okay, what the term used, the rupture of the fetal membrane just before the onset of the labor. Okay, so yes, before the onset of the labor means only just they given before the onset of the labor, so that is the premature rupture of the membrane. Okay, if they have given the answer before the onset of the labor, okay, at the 35 week, okay, then what is the answer? Then what is the answer? In question they have mentioned that yet the membrane is get rupture, yes, before the onset of the labor at the 35 week. So now what is the answer? Very nice of you all. Okay, so that is the, yes, option A, PPROM. Okay, that is the premature rupture of the membrane is your answer. Okay, hi. Why? Because it is a rupture of the membrane which is occurring before 36 week. Okay. So, but the in question they have didn't given anything. So yes, they have just given that is the before onset of the labor. The answer will be the premature rupture of the membrane. So then, what is the meaning of the ARM, artificial rupture of the membrane? Student, if in case of this membrane, the complete dilation of the cervix occurred, but this membrane is not rupturing, means the labor is not progressing. At that point of the time, yes, the healthcare provider, okay, with the help of the sharp instrument, okay, slowly he will prick to this membrane and he will try to rupture it artificially. So, in order to increase the speed of the labor, so that is what we call as in the artificial rupture of membrane. Okay, so yes, that is what we call as in the artificial rupture of membrane. Okay, students, there are two words you have to consider. Yes, okay. So in case of the labor progress is so in for the okay labor, so the uterus is quiescent, silent. Okay, so there is no any start of the contractions. Okay, so in a quiescent means in a silent uterus, we are giving the medications like oxytocin. Okay, and we are starting the labor in a quiescent uterus. Okay, where the labor still not yet started. Okay, we are starting it artificially, means this is what we call this one the induction of labor. What we call this one as in the induction of labor. Okay, in case the labor process have started, but the progress is slow. But the progress is slow means in order to make the progress speed. Okay, so in order to increase the progress of the labor, we are yes rupturing the membrane, that is the artificially rupturing the membrane, or we are giving the same oxytocin. Okay, so this techniques we call as in the yes the augmentation of the labor. Okay, augmentation of labor. ಓಕೆ, ಇಲ್ಲಿ ಎರಡು ರೀತಿಯಾದಂತಹ ಸಿಚುವೇಶನ್ ಇದೆ. ಒಂದು, ಮದರ್ ಯೂಟ್ರಸ್ ಫುಲ್ ಸೈಲೆಂಟ್ ಆಗಿದೆ, ಕ್ವಶೆಂಟ್ ಆಗಿದೆ, ಏನು ಸ್ಟಾರ್ಟ್ ಆಗಿಲ್ಲ ಇನ್ನು ಲೇಬರು. ಆ ಮದರ್ ಯೂಟ್ರಸ್ ಅಲ್ಲಿ ನಾವು ಕಂಟ್ರಾಕ್ಷನ್ ತಗೊಂಡ್ಬಂದು ಎಸ್ ಲೇಬರ್ ಪ್ರೊಸೆಸ್ ನ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ತಿದ್ರೆ ಅದಕ್ಕೆ ನಾವು ಇಂಡಕ್ಷನ್ ಆಫ್ ದಿ ಲೇಬರ್ ಅಂತ ಕರಿತೀವಿ. ಓಕೆ, ಸೊ ಇನ್ ದ ಕ್ವೆಶೆಂಟ್ ಯೂಟ್ರಸ್ ವಿ ಆರ್ ಸ್ಟಾರ್ಟಿಂಗ್ ದ process of the labor, means that is what we call as in the induction of the labor. But the labor is already started, but it is slow. In order to increase the speed, so we are yes doing the something by rupturing the membrane, by giving the oxytocin. Yes, this is what we call as in the augmentation of the labor. So two words, yes, you have to basically consider what is the induction of the labor, what is the augmentation of the labor. Hope the concept is clear for this one. Yes, clear bachcho, clear. Okay, so that is what we call as the artificial rupture of the membrane, means we are artificially as a healthcare provider we are rupturing the membrane. So that is what we call artificial rupture of the membrane. And the answer for this question is the yes, that is the premature rupture of the membrane. Okay, hope the concept is clear for this question. Okay, clear bachcho, each and every word we have discussed in detail and very easy and understandable manner. Okay, clear. So here is the next question. The umbilical cord typically contains which of the following structures? Yes, so umbilical cord typically contains which of the following structure? Option A is telling that two arteries and one vein. Option B is telling that two veins and one artery. Option C is telling that three veins and one artery. So option D is telling that one vein and one artery. So what is the yes umbilical cord typically contains? I want your comment. Okay, so it should be like Vande Bharat Express train. Okay, so that speed of the comment I want from you all. Okay, okay. Why? Because this is the yes frequently asked question. Okay, this is the frequently asked question. Yes, students, very basic. The umbilical cord typically contains yes, that is the V1 A2. Okay, so V1 A2 means one vein. Yes, one vein and two arteries. Students, so if the question is given like this, so the umbilical cord contains typically which of the following structure before 16 week or before the 4 month. Okay, before the 4 month of the gestation or before the 16 week of the gestation means yes, the umbilical cord that time containing the two vein and two arteries. Okay, so two vein and two arteries. Okay, yes, students, very basically we have to consider okay before 16 week or before 4 months. Okay, the content of the umbilical cord, if someone is asking to you, means that is the two vein and two arteries. Yes, that is the right umbilical vein, then left umbilical vein, then arteries are right umbilical artery, then left umbilical artery. Very basic. But after the 14 month, sorry, after the 4 month or after the 16 week, okay, so this is what I told, that is the before 4 month or before the 16 week. Yes, the umbilical cord content is the, yes, two veins, two arteries. Okay, but they have not mentioned anything in the option. So they have not mentioned anything in the question, means they are asking the question related to the after 4 month. Okay, so always consider that is the after 4 month. So you have to give the answer, that one as in the, yes, V1 and A2. That is the two veins and, sorry, one vein and two arteries. Okay, that's the one vein and two arteries. So now tell me, which vein will get disappear, whether the right umbilical vein or the left umbilical vein. Okay, so right umbilical vein right ಹೇಳುತ್ತೆ ನೆನ್ಪಿಟ್ಕೊಳ್ಳಿ. Yes, the right umbilical vein right ಹೇಳುತ್ತೆ. Okay, yes, ತಿಳಿತಲ್ಲ. So right umbilical vein will get disappears. So after that only one vein will get remaining, that is the left umbilical vein. So then two umbilical arteries. Okay, so these are the content of the our, yes, these are the content of the our umbilical cord. Okay, clear bachcho, clear. So after 4 months or after 16 after 4 months or after 16 week, we are having the one vein and two arteries. Okay, so before 16 week or the before 4 months, if specifically they are asking, means we are having the two veins and two arteries. Clear bachcho? Yes, yes, very nice of you all. Okay, here is the next question for you all. Yes, which nerve root are affected by the Erb's palsy? Again, most important question. Most important. Yes, the concept I will teach you here is the most important only. Okay. Yes. So we have studied that there are eight cervical nerves. Yes. There are 12 thoracic nerves. There are five lumbar nerves. There are five sacral nerves. There are one coccyx nerves. Total 31 pair of the nerves we are having. Okay. So here in these nerves we have divided as the cervical plexus. Okay. Brachial plexus. Then lumbar plexus. Okay. So yes, students. Yes, the plexus of the nerve root I have already thought you in the, yes, the questions of my nervous system. Okay. The playlist is there related to the nervous system. There I have discussed completely related to stroke. Okay, what is hemorrhagic stroke, what is ischemic stroke. Then I have discussed completely related to the seizures, what is the epilepsy, what is the seizure, what is the convulsion, what is the nursing management as a nursing officer you have to do in the seizures, and myasthenia gravis. Okay, Guillain-Barré syndrome, each and everything related to the nervous system I have discussed in the playlist of the nervous system. Okay, do visit the master nursing classes playlist part. There you will be getting the, yes, RRB previous year questions. Okay, the questions related to the endocrine system, respiratory system, nervous system. Okay, the system wise I have separated, and the already videos are posted in my YouTube channel. So do watch the videos completely. So you will be getting the huge knowledge. Okay, that will break. Okay, not only cracking the exam, that will be breaking the exam. Okay, yes, that is the very important. Which nerve root are affected by the herb palsy? Yes, can anyone able to tell? Very nice of you all. Okay, many of you have given the answer. That is the, yes, that is the C5 and C6. Okay, so damage to the C5 and C6 will leads to the herb palsy. Okay, so what happens? This is the component of the brachial plexus. Okay, so this is a component of the brachial plexus. So injury to this brachial plexus. Okay, so injury to this brachial plexus, if the injury is the level of the C5 and C6, okay, which we, that one we call this one as in the, yes, Erb's palsy. If in case this C7 and T1 also part of the brachial plexus, if any injury or damage to this particular C7 and T1, so that one we call as in the Klumpke's palsy. What we call that one is the Klumpke's palsy. Okay, that is what we call as the Klumpke's palsy. So yes, Klumpke's palsy is the damage to the C7 to, yes, T1, and the Erb's palsy is the damage to the C5 to C6. So now tell me, so among these two, so Erb's palsy and Klumpke's palsy is there. So which one we can call as the policeman tip or the waiter's tip? So which one we can call as the policeman tips or the waiter's tips? Students, do you know in the hotel? So in the hotels, so how what happens actually when you will be went for the having the dinner or the lunch in the hotel? Okay, so this is your table of the food. Okay, here you are having the plate. The server or the waiter will come, he will serve the food. Okay, so consider he is the your waiter. Okay, he will be serving the food. Okay, after serving the food, okay, so after having the lunch, he will come and he will ask for the tips. So how he will ask for the tips? He will turn. Okay, he will turn towards the counter, so his back will be facing to you. Okay, and his arm will be like this. Okay, his arm will be like this. Sir, please give me something. Sir, please give me something, like. Okay, so this is what we call as the waiter's tips hand. Okay, so this is what we call as the waiter's tips hand. What happens in the waiter's tips hand? Okay, so the hand will be adducted. Okay, the hand will be adducted. Okay, yes. So what is the adduction? Adduction means, yes, the hand will be coming towards the body. That is what we call the adduction. What is the abduction? Abduction is the hand will be going out of the body. That is the abduction. How you can remember? Do you know the our ex RCB player? That is the ABD. ABD Villiers. Can you know people? ABD Villiers. Yes, the 360 player of the cricket. So ABD means he is foreign player. Means he is out of country player. He is out of country player means the body is the hand is going outside the body or away from the body. We can say the abduction. The hand is coming towards the body. We can say the adduction. Okay. So here A double D, that is the add. Add means add towards the body. Okay. Add means taking towards the body is the adduction. Okay, taking away from the body is the abduction. Very simple. Okay, but in the earth palsy, what happens? Yes, the person hand is completely adducted and unable to abduct. Okay, completely adducted means he is unable to adduct the hand. Okay, then pronation of the forearm will be there. Okay, so the elbow will be extended. Elbow will be extended. Why I am teaching this much details means this is asked already in the question, students. In the other exams, this is already asked. Okay, the elbow will be extended. Okay, remember elbow extended. Okay, elbow is extended. Yes, the shoulder is adducted, elbow is extended, and wrist is flexed. Okay, and backside wrist is flexed and backside, and this particular arm is pronated like this. Pronated. Okay, so the forearm is pronated, and the wrist is flexed. The wrist is shoulder is adducted, then elbow is extended, the forearm is pronated, and wrist is flexed. Okay, so this is I will be getting the image in the Google. Okay, with the Erb's palsy, you can watch after the this video. Okay, so just type Erb's palsy in the Google. Okay, so you will be getting the like video also, and you will be getting the yes the images for also this one. Okay, so just see the image. That is the yes what happens in the Erb's palsy due to the damage to the C5 and C6. Yes, that is the adduction of the shoulder. Okay, extension of the elbow, then pronation of the forearm, and flexion of the yes wrist. So it will be like asking the tips for something. Okay, polices also they will ask the tips if you caught by anything. Okay, yes, if you caught by the police, so they will ask for the tips like this only. Okay, this is just for educational purpose. This is just they are given in the books. I am saying that's it. Okay, yes, is that clear, bacho? Clear? Yes, very nice of you also. The Erb's palsy is also called as the policeman tip, or the Erb's palsy is also called as the waiter's tip. Okay, Erb's palsy is also called as the waiter's tips. So this is basically how to know because they have asked in the exam. Clear, bacho? So yes, the Klumpke's palsy we call the Klumpke's palsy. Okay, CLUM. Okay, PKI apostrophe S. This is the Klumpke's palsy. So in the Klumpke's palsy, what happens? Yes, so there is involvement of the ulnar nerve is also there. So ulnar nerve will get damages. So these last two fingers. Okay, so that is the small finger and the ring finger. Okay, so this will be like this. So these two fingers are the flexed fingers because these fingers are unable to extend in the Klumpke's palsy. So the hand is looking like a claw. This hand is looking like a claw now. So this is what we call as the claw hand syndrome. So this is what we call as the claw hand syndrome, which occurs in the ulnar nerve damage. So ulnar nerve is a branch of the CO7 and T1. Okay, so it will be originating from the C7 to T1. So the ulnar nerve damage means yes, the claw hand syndrome occurs. So this is what we call as the Klumpke's palsy or the claw hand syndrome. very much basically you have to know related to these things. Okay, Ars palsy is also called as the Vetter stiffs palsy. Ars palsy is also called as the, yes, policeman tip. Okay, Klumpke's palsy is also called as the, yes, claw hand syndrome. Okay, this is the basic you have to know related to the these pulses. Okay, so in option A, you are seeing that is the C1 to C4. Okay, so C1 to C4, cervical 4, where from our diaphragm nerve will originate. Okay, what will originate? Our diaphragm nerve will originate. Okay, so diaphragm nerve will originate from the cervical 4 root of the spinal canal. Okay, so student, the diaphragm is a main muscle of respiration for our normal respiration, which is the one most important and most important nerve, means that is the our diaphragm. If in case damage happens to the diaphragm nerve root, that is the C4, means there is diaphragm palsy. There is diaphragm palsy, means always remember, if in case the injury of the spinal cord is more than the our C4 level, or at the C4 level, the nursing priority responsibility is to check the respiratory function of the patient. The her bar asked question in your exam. Okay, remember. Okay, damage to the C4, that is the diaphragmatic palsy. Damage to the C5, C6, that is the brachial palsy. Damage to the C7 and T1, that is the Klumpke's palsy. Let it make a sequence. Yes, that is, let it make a sequence and read very easily. Okay, so yes, I am writing that is the C1, C2, C3, C4, C5, C6, C7, T1. Okay, yes, damage to this C7 and T1, that is what we call as in the Klumpke. Okay, Klumpke's palsy. Yes, damage to the C5 and C6, we will call this one as in the Erb's palsy. What we call this one as in the Erb's palsy. Okay, so then, yes, damage to the C4 and above, this may leads to the diaphragmatic palsy. Okay, this may leads to the diaphragmatic palsy. Okay, so among these, which one is danger? Your hand is working, means not any danger. Okay, so yes, your hand is not extending, flexing, means no any problem, but your diaphragm is working, means if your diaphragm is not working, means it will send you up in the life, that is death. Okay, yes, this is the, so, yes, it will leads to the death. Okay, C4 and above, especially at the C4, especially one single best answer is the, yes, damage to the C4 level, which leads to the diaphragmatic palsy. Remember, students. Okay, yes, remember. Here is the next question, bachcho. Hope the answer is clear for the last question. Yes, that is the Erb's palsy is the C5 C6 injury. Okay, so this all things comes under the brachial plexus injury, but diaphragm palsy is not comes under brachial plexus injury because it is the, yes, and comes under the cervical plexus. Okay, not in the brachial plexus. Is that clear? Clear. Okay. So here is the next question. The normal length of the umbilical cord. Normal length of the umbilical cord. So option A, that is the 20 to 30 centimeter. Option B, that is the, yes, 30 to 100 centimeter. Option C, that is the 50 to 70 centimeter. Option D, that is the 70 to 90 centimeter. Okay, so what is the normal length of the umbilical cord typically? Okay, students, remember, yes, few of you have given the correct answer. That is the option B. Okay, so always remember. So length will starts from the 30 centimeter, it will go till 100 centimeter. Okay, so the length less than 30 centimeter. Okay, this is what we call as a short umbilical cord. Okay, this is what we call as in the short umbilical cord. Okay, what is the risk in the short umbilical cord? Okay, the umbilical cord is short, means it will not allow the baby to move. Okay, so there is the, yes, restriction to move. Okay, there is a restriction to move. Okay, so then, yes, there is a chance of the abruptio placenta, means the baby will move forcefully, means the placenta will come along with that. That is the placenta will separate from the uterine layer. So suddenly before the third stage of the labor, that is what we call as the abruptio placenta. Okay, if in case the umbilical cord is more than 100 centimeter, yesterday we have discussed it. This is what we call as in the long cord. What is we call this one as in the long cord. Okay, so if the umbilical cord is very long, it can, yes, circumference the head of the baby, it will comes around the neck of the baby. So if the umbilical cord is coming around the neck of the baby, okay, and it is like it is making the neck too tight, okay, so that is what we call as the cord entanglement. What is we call that is the cord entanglement. What is the cord entanglement? Cord entanglement is the, yes, the umbilical cord surrounding the neck of the baby, and which is making the baby to, yes, difficult for the aspirate, difficult for the breath. That is what we call as the cord entanglement. Its highest risk is there in the long cord. And okay, so if the long umbilical cord means the cord may comes before the head of the baby only, so there is cord presentation, cord prolapse. Okay, so these are the highest risk in the long cord. Okay, yes, clear bachcho? Yes, even if it is the answer that is the 52 centimeter, this is the best range. That is the 30 to 100 centimeters the best range. So this is only given in your book. Okay, yes, the book which will be referred by the aims for the considering the answer. Yes, that is the DC Datta's book. Okay, so in that book, so it is given the 30 to 100 centimeter. So always the best answer is the 30 to 100 centimeter. So ideal one single length if you want to answer means that is the 50 centimeter is the one single best answer. Okay, clear bachcho? Clear, 50 centimeters is the one single best answer, but the range starts from the 30 to 100 centimeter. Short cord means less than 30 centimeter. Long cord means more than 100 centimeter. Clear bachcho? Clear? Very nice of you all. Okay, so here is the next question. Yes, the Battledore placenta is typically diagnosed using which of the following investigation? Option A is telling that ultrasonography. Option B is telling that, yes, X-ray. Option C is telling that MRI. Option D is telling that there is the CT scan. Okay, so yes, do comment in the comment box. Fadafat. So yes, bachcho, a Battledore placenta is typically diagnosed using the which one? Yes, can anyone able to tell answer for this question? Yes, what is the Battledore placenta? Okay, let me explain what is Battledore placenta. Okay, the answer for this question will be the option A. There is the ultrasonography. I will come to this option. Okay, so just wait. Okay, that is the Battledore placenta. Students, as all of you know that in yesterday's session we have discussed this is the this is the our beautiful placenta. Okay, so the umbilical cord of the placenta should and must it attach to the center of the placenta. Okay, this is the normal. Okay, this is the normal. If in case this is the placenta, this is the placenta. Okay, if the umbilical cord attaches to the margin of the placenta, this is what we call as in the, this placenta we call as the Battledore placenta, and this umbilical cord we call as the marginal insertion of umbilical cord. Okay, so marginal insertion of the cord is the this umbilical cord. Okay, this placenta we call as the Battledore placenta. Okay, what happens? The, yes, where it should attach, the umbilical cord should attach, should and must attach the middle of the placenta. It is attaching the margins of the placenta. That is what we call as the Battledore placenta. So this can be diagnosed in the antenatal period only by using the ultrasonography. Okay, so always remember the confirmatory test for the pregnancy. The confirmatory test for the pregnancy is the ultrasonography. The safest test in the pregnancy is the ultrasonography. Okay, so the test which is used to assess the fetal anomaly, that is also ultrasonography. Okay, yes, clear bachcho? That is also ultrasonography. Okay, X-ray, MRI, CT scan are contraindicated in the pregnancy. Okay, only is used if necessary, means that only that point time of the part are used, but it is after approval of the, yes, the medical board. Okay, is that clear? Clear. So the answer for this question is the ultrasonography. The pregnancy confirmatory test for the pregnancy is ultrasonography. Yes, the scan which is done to assess the fetal anomaly is also ultrasonography. Okay, safest investigation in the pregnancy is the ultrasonography. That is what the USG is the, yes, the investigation of choice or the confirmatory test for the pregnancy. Clear bachcho? Clear. So when we will be doing the, yes, TPA test. What is the TPA test? What is the TPA test bachcho? What is TPA test? So this is the targeted imaging for fetal anomaly. Means, so at the 18 to 20 week of the gestation, So complete all organs of the babies are generated. Okay, at this point of the time, almost all organ system of the babies is generated. So at this point of the time, we have to do the TPA test. Okay, that is the ultrasonography. Ultrasonography. So in this one, yes, the name itself telling that it is a targeted imaging. So the radiologist will target to whom he will target. He will target, yes, the babies each and every part. Okay, so the babies each and every part. So in order to assess whether there is any anomalies in the baby. Okay, so that is what he is targeting each and every part. He is taking the image for assessing the fetal anomaly. Okay, so that is what you call as the targeted imaging for fetal anomaly scan. Okay, that is what you call as the TPA scan. The ideal time of doing the TPA scan is the again 18 to 20 centimeter. Okay, why this period only? Because at this period the almost all organ system of the babies are generated. So that is what you call as the TPA scan. Remember, this is the most important. Okay, this is the 10 star. Okay, this is the 10 star. Write it in your last minute revision and revise before going the exam. Okay, but you clear this one? Yes, very nice of you all. Okay, so here is the next question. So here is the next question. Yes, I already discussed the question. Just I want answer from you all. So this is also style of the questions they will ask on that particular topic. Okay, already just in the I think 2 to 3 minutes back only we have discussed this question. Okay, so which of the following is a classical typical finding of the patient with a brachial plexus injury involving the upper trunk? Okay, so involving the upper trunk, as I told, in the brachial plexus C5, C6, C7, T1. Okay, so this is called upper trunk. This is called the lower trunk. Okay. Yes, this is the Klumpke's palsy. This is the Arps palsy. Okay. So here's the brachial palsy. Brachial in this both totally we call this is the brachial plexus. In the brachial plexus, this is the upper motor neuron. Sorry, this is the upper part of the brachial palsy. This is the lower part of the brachial palsy. Upper part of brachial palsy is damaging means that is called as the Arps palsy. Lower part of the brachial nerves are damaging means that is what we call the Klumpke's palsy. Okay. Clear? Clear, bachcho? Clear. Okay. What I told, that is the yes, almost all of you have given the answer. That is the classical physical finding of the yes damage to the C5 and C6 is the Arps palsy. That is the classical features in the Arps palsy is the Vater's tips posture means. So the patient will make a such a posture like abduction of the shoulder, then extension of the elbow, then pronation of the hand, then flexion of the wrist like this. So this is the yes the posture that maintained by the patient. So it looks like a yes the waiter, the hotel waiter is asking for the tip or the policeman is asking for the tips. Okay, so for the tips. Understood? Yes, this is what we call the yes the brachial plexus injury. In that one, upper motor injury, that is the C5 C6. That is what we call the Arps palsy. In the Arps palsy, water tip posture or the policeman tip will be there. Okay, clear, bacho? Clear. Okay. So then option D is telling here what it is telling. That is the drooping of the eyelid. Okay. So drooping of the eyelid. What we call for the drooping of the eyelid. So this is the early sign of the which disease, which neurological condition. Yes, drooping of the eyelid is the early symptom of the which neurological condition. Yes, the drooping of the eyelid, very nice of you all. That is also called as the ptosis. Okay, so what we call this one as the ptosis. This is the early manifestation of. Okay, this is the early clinical feature of the yes. That is the myasthenia gravis. Okay, myasthenia gravis is a disease of the neuromuscular junction. Okay, where there is a deficiency of the acetylcholine neurotransmitter is there, or else there is damage to the acetylcholine receptors by the autoantibodies. So which leads to the weakness in the muscles. Okay, which leads to the weakness in the muscles. Already in detail, 1.5 hour or else 2 hour video lecture is there in my neurology playlist. Okay, so just do visit the playlist, check out the neurology session. So each and everything in detail related to the myasthenia gravis. What is the cholinergic crisis? What is the myasthenia crisis? Each and everything we have discussed in detail in our neurology session. That is clearly, solely, perfectly discussed. So yes, you can watch the video for detail. Okay. So now is the yes the drooling of the eyelid is the that is called as ptosis. This is the earliest clinical manifestation of the myasthenia gravis. Okay. Clear, bachcho? Yes, very nice of you all. So the answer for this question is the option A. That is the waiter's tips. Hope the concept is clear. Very nice. So here is the next question. Yes, which of the following is true regarding the amniotic fluid at the term? Okay, so which of the following is true regarding the amniotic fluid at the term? Yes, bachcho. So the option A is telling that yes, they are asking the question at the term. Okay, at the term means yes, the pregnancy is at the yes level of the 37 to 38 week. Okay, this is called as the term pregnancy. Okay, till 48 weeks, till 40 weeks it will be called as the term. Okay, so after 42 week of the gestation, so we call this one as the post term. Okay, so let me take a new slide, so it will be it will be clear for you. Okay, so what is term, what is preterm, then what is post term? Yes, the preterm means the pregnancy before the 36 week of the gestation, we call this as the preterm. The term means yes, the pregnancy of the 37 to 40 week, we call this one is the yes, the preterm, and the postterm is the more than 42 week if you went means. So this is what we call as the yes, the postterm. Okay, clear bachcho, this is what we call as the postterm. The question is related to the preterm. Okay, so the question is related to the term. So at the term, what is the uh, which of the following given this one related to the amniotic fluid, the statement is correct, they are asking. Okay, so the volume of the amniotic fluid is typically 5 to 10 ml. Bachcho, at the term the volume of the amniotic fluid will be 800 to 1000 ml. Okay, so not 5 to 10 ml, so I am eliminating this option. Okay, so then option B is that yes, the amniotic fluid volume peaks around the 24 weeks of the gestation and gradually decreases afterward. Yes, it will be peaking at the our 38 week of the gestation, exactly at the term it will be in the peak. So after that it will start decreasing. Okay, but not at the 24 week. So option B also I am eliminating. Okay, why? Because the amniotic fluid will be in the peak at the yes 48 week of the gestation. Okay, so write it down, the amount of the amniotic fluid. So and according to the period of the gestation. Okay, at the 12 week, at the 12 week the amniotic fluid will be only 50 ml. Okay, it is only 50 ml. Then at the 20 week the amount of the amniotic fluid will be 400 ml. Okay, so make double of this 2, that is the 4, make double of this 0, that is the double 0. At the 20 week of the gestation, that is the 400 ml. Okay, so then at the 38 week or from the 36 to 38 week of the gestation. Okay, so it will be the our very importantly yes 800 to 1000 ml. Okay, so after this at the 42 week it will comes to 200 ml, it will comes to 200 ml means at the post term amniotic fluid will be decreases, at the term it will be at the peak. Okay, so again at the preterm it will be decreased. Okay, so in the preterm at the 12 week it is only 50 ml. Okay, at the 12 week it is only 50 ml, at the 20 week it will be 400 ml, at the 36 to 38 week, at the 36 to 38 week, so it will be at the peak, it will be at the peak, that is the 800 to 1000 ml. Okay, and after 42 week in the post term, okay, in the post term it will always again decreased. Okay, in the post term it is again decreased to 200 ml. Clear bachcho? Yes, is it clear? Very nice. Yes, here is the next question. Yes, here is the next question. So what is the question? So what is the oligohydramnios in the second trimester is the most commonly caused by? So the question is very simple, the oligohydramnios in the second trimester is most commonly caused by. Yes, oligohydramnios in the second trimester is most commonly caused by. This question is simple. So first we will know what is the uh, oligohydramnios. So then we will come for this question. Okay, students. So what I told, this is the amniotic cavity. In this amniotic cavity, we are having the amniotic fluid. Okay, so we are having the amniotic fluid. Okay, so we are having the amniotic fluid here. Yes. So when we will divide the mother abdomen in four part. Okay, so and we'll check for the pocket of the amniotic fluid. Okay, yes, we'll check for the pocket of the amniotic fluid in each quadrant. Okay, I will clear you what is amniotic fluid index. I am telling now that is the amniotic fluid index, then I will come for the question. Okay, so this is the our process of assessing the amniotic fluid index. So with the help of the ultrasonography, we will make the mother abdomen 4 divided part, that is the A, B, C, and D. Okay. So in each and every pocket, we will assess the depth of the largest pocket. So in this one, this is the in A pocket. So this one is the largest pocket. In the B pocket, this is the largest pocket. In the C pocket, this is the largest pocket, and in the D pocket, this is the largest pocket. So among these four pocket, the largest pocket length we will write. Okay. For example, the largest pocket length in the A will be the, yes, that is consider this one as in the 6 centimeter. Okay. Plus the largest pocket depth in the B will be the, yes, 8 centimeter. Okay. Then add, so the largest pocket depth in the C will be the, yes, again 10 centimeter. Okay. So plus then the largest pocket depth in the what we call D will be the, yes, the 4 centimeter. Okay. So consider that is the we have to add all these things. Okay. So that is the 6, 8, 10, 4. Okay. So 4 plus 6, that is the how much? 4 plus 6 will be the 10. So then 10, 20, 28. Okay. So 28 centimeter it is going. Okay. So let me make a correction here. So it will be first I will tell the what is normal, then we'll go for the abnormal. Okay. So the like this one, the pocket depth of the C will be the, yes, that is the, we'll consider again it is the only 4 centimeter. Okay. So the final answer will comes here as the 4 centimeter, 24 centimeter. Okay. So the total depth of the all pockets will be the 24 centimeter. So the normal amniotic fluid index will be the 5 to 25 centimeter. This is the normal amniotic fluid index. Okay. So this is the normal amniotic fluid index. Okay. So how we have assessed the amniotic fluid? With the help of the ultrasonography, we have divided the mother abdomen into 4 cavity. That is the cavity A, cavity B, cavity C, and cavity D. So among these cavity, we have, yes, assessed the length of the depth one. Okay. So it is which will be in the deepest pocket. So that is we have assessed in each and every cavity. So the length of the each depth cavity will be written here. Okay. Then all will be added. Okay. Added together. So if it is coming between the 5 to 25 centimeter means, so this is the normal amniotic fluid index. Okay. If in case, what is the oligohydramnios? What is the oligohydramnios means? Yes, the amniotic cavity, the amniotic fluid index is less than what I told. The normal is the 5 to 25 centimeter. The amniotic fluid index is less than 5 centimeter. We call this one as the oligohydramnios. If it is more than 25 centimeter, we call this one as the polyhydramnios. There are two simple words in the medical system. There is the oligo and poly. So oligo always stands here as the low. Okay. So that is the oligo means low. Okay. So oligohydramnios. Okay. So then this is the polyhydramnios. Polyhydramnios. So hope the concept is clear. What is the normal amniotic fluid index? 5 to 25 centimeter. If it is less than 5 centimeter, oligohydramnios. If it is more than 25 centimeter, polyhydramnios. Okay. In the oligohydramnios, the, yes, the amount of the fluid at the term will be less than 800 ml, and here it will be less than here it will be more than 2000 ml. Okay. Here it will be more than 2000 ml. So okay. So this is the very basically how to consider here. Okay. So this is what we call as the oligohydramnios and the polyhydramnios. ठीक है बच्चों? ठीक है. So then what is the region where the less amniotic fluid will be there? That is what we call the oligohydramnios. So what is the region where we will be finding the less amniotic fluid? बच्चों, what is the region where we will be finding the less amniotic fluid? Yes. So you have to understand the basics, then you have to understand the reason for the oligohydramnios. Students, so the main source of the production of the, yes, the amniotic fluid in the baby will be the urine of the fetus. Okay. So in the amniotic cavity, the main source of the amniotic fluid will be the urine of the fetus. Okay. So urine of the fetus is the main source. Let me adjust the pen here, please just wait. Yes, that is the main source of the amniotic fluid is the, that is the urine of the fetus. So urine of the fetus is the main source. If in case the renal agenesis is the presence, means renal means kidney, agenesis means production. So the kidney is not formed properly, the kidney defect is there, means there is no urine. There is no urine means the less amniotic fluid. The less amniotic fluid means that is what we call as in the oligohydramnios. omnios. Clear, bachcho? That is what you call as the oligohydramnios. Okay. Yes. So what I told, the amniotic fluid will be source of the amniotic fluid will be, that is the urine of the fetus. The main source is the urine of the fetus. So urine will be produced by the kidney. So if there is any renal agenesis or the defect in the kidney, the urine will be not produced. So urine will be not produced means the less amniotic fluid will be there. So that is what we call oligohydramnios. Okay, very importantly you have to know. Very basic and very basic. Okay, so yes, so what happens in the questions, let me see. This is the main reason. Okay, so oligohydramnios in the second trimester is the most commonly caused by, yes, option is that fetal renal agenesis. This is the most common. Okay, actually most common cause is the unknown. Okay, so actually most common cause, if the examiner asking for, is the most common cause for the oligohydramnios is the unknown, or you can say idiopathic. Okay, so but the pathophysiology indicates that is the fetal renal agenesis, which leads to the commonly cause of the oligohydramnios. Okay, so what happens in the maternal diabetes, as I told, is the main source of the amniotic fluid is the fetal urine. Okay, maternal diabetes means increased glucose in the mother. So increased glucose in the mother means increased glucose in the fetus. Increased glucose in the fetus means, yes, what happens in the diabetes, what happens in the diabetes, yes, diabetes is the, which will leads to the, yes, polyuria. Okay, it will leads to the polyuria. Which kind of the polyuria? That is the osmotic polyuria. Okay, yes, polyuria means the fetus will produces the more urine. The more urine produced by the fetus means in the diabetic mother, the more amniotic fluid will be there. So diabetic means maternal diabetes, it will be causing the, yes, that is the polyhydramnios, not oligohydramnios. Okay, so I am eliminating the option B. Okay, clear, bachcho? In maternal diabetes it will leads to the polyhydramnios. Okay, in the multiple pregnancies, again, yes, this is what we also call as the twins pregnancies. In the twins pregnancies, two babies will be there, two baby urine will be more. So urine will be more means again the polyuria. Okay, in the spinal bifida, what is the spina bifida? Yes, bachcha, what is the spina bifida? Spina bifida is the, yes, you have to understand the basics. That is the, what is neural tube defect. In the neural tube defect, we are having the two parts. That is the defect of the cranium. Okay, so then defect of the spinal cord. Okay, defect of the cranium is defect of the brain, we can consider. Okay, if in case there is absent in the cranial vault, so there is no any cranial vault is there in the babies means, that is what we call as the, yes, what we call this, that is the anencephaly. So that is the anencephaly. A means absent. Okay, cephaly means brain. Okay, here in this kind of the charts, there is no any brain only. So there is absent of the cranial vault. That is what we call the anencephaly. Okay, in the spinal cord, yes. So again, we are having the, yes, the spina bifida types. That is the spina bifida. Okay, occulta. What is the spina bifida occulta? Yes, wherever the word occult comes means that is the hidden. Okay, that is wherever the word occult comes means the meaning of the occult will be the hidden. Okay, so spina bifida occulta means, yes, the first we have to understand what is the spina bifida. Spina bifida is the, yes, so posteriorly to our vertebral column, it is completely closed, and it should not be any leakage of the like what we can say, that's the spinal membrane or the spinal column. So it should not any protrusion of the, it should not be any protrusion of the spinal column. Okay, if in case the spinal membrane is protruding out, the spinal membrane is protruding out. Okay, it should be ideally like this. Okay, let me make a diagram and let me clear for you all. Okay, so ideally in the normal, okay, normal neural pore development. Okay, so this is the vertebrae means, yes, this is the vertebrae means. So here will be the, yes, center of the vertebrae through which our spinal canal will run. Okay, so through which the spinal canal will be run. So if in case there is any problem in the formation of this posterior vertebrae, so at that point of the time, so this spinal cord will be, yes, the spinal canal will be protruding like this. Okay, so this is what we call this one as the spina bifida. Okay, it is protruding like this because of the agenesis or the dysgenesis of this posterior spinal canal. Okay, that is what we call the spina bifida. Okay, so on this one skin is there means, so it is hidden. Okay, this is what we call the, yes, the spina bifida. Okay, this is what we call the spina bifida. That is the hidden. That is what we call the occulta. Okay, so occult. Okay, occult stool in the blood we can say. Okay, occult blood in the stool we can say. Okay, so that is the occult blood in the stool means the hidden blood in the stool. Okay, so the okay, the many more words will become here. Okay, yes, so the basic word means the occult here means hidden. Why? Because on this protruded cyst of the spinal canal there is a skin will be there. So on the skin, okay, there is tuft of the hair will be there. Okay, so yes, the protrusion will be there at the sacral region of the baby, and on the protrusion, okay, so there is the, yes, on the protrusion there is a tuft of the hairs will be there. So this is what we call as in the, yes, this is what we call as in the spina bifida occulta. Okay, so bachcho clear this one? Clear? Okay, so yes, yes, hope the concept is clear here. Yes, so if in case this skin is not there, means this is will be protruded out. Okay, so this will be protruded out like this. Okay, so without skin it will be protruded out like this. So I'm eliminating the skin here. So yes, the skin will comes like this and like this. So this will be protruded out. So this is what we call as in the spina bifida. The cyst will be there. That is what we call as in the cystica. Spina bifida cystica means, yes, there will be no covered by the skin and the cyst will be there at the posterior sacral region. So this is because also, yes, the dysgenesis of the posterior spinal vertebrae. Okay, that is what we call the spina bifida cystica. Okay, so in the spina bifida cystica, again two words will be called. That is the meningocele, meningocele, then mylo meningocele. Okay, cele means the cyst. The cyst is there. The cyst is only it containing the, yes, the spinal membrane. Only it containing the spinal membrane. Okay, so no spinal nerve. No spinal nerve. Okay, the protrusion of the spinal membrane is there, or we can say the spinal membrane. What is the like the membrane which covering the brain and spinal cord? That is the meningeal membrane, right? Yes, we can say the spinal membrane is the meningeal membrane. Okay, so there is only protrusion of the meningeal membrane. Okay, there is only protrusion of the meningeal membrane. Okay, no nerves will be protruded. So that is called meningo means meningeal membrane seal. Okay, the seal will means the cyst will be there. But with the, along with the, yes, the meningeal membrane, the protrusion of the spinal nerve also there inside. Okay, so the protrusion of the spinal nerve is also there inside. So that is what we call as the mylo means the nerve, meningo means the meningeal, seal means the cyst. So mylo meningo seal means, yes, the protrusion of the meningeal layers, along with that the nerve also protruded through the defected part of the spinal cord. So that is what we call the mylo meningo seal. Okay, hope the two words are clear here. Only meningeal membrane protruded. Okay, meningeal membrane with CSF. Okay, without any nerve root, that is the meningocele. Meningeal membrane, CSF with nerve root, it is protruded means that is what we call the myelomeningocele. Okay, so these are the basic types of the, yes, the spinal cord defect you will be seeing here. Okay, so yes, where is our classification? Yes, let me take a slide. Okay, so yes, so this is our, yes, spinal cord defect. So hidden will be the spinal cord, spina bifida occulta. So one more is the spina bifida cystica. In the spina bifida cystica, yes, we are having the like meningocele, then meningocele. Okay, so in the meningocele only meningeal membrane is protruded with the help of, with the CSF, and meningocele, yes, meningeal membrane plus nerve root also protruded. This is the basic thing we have to identify. Okay, this both terms so repeatedly asked in the questions. That is the meningocele and meningomyelocele. Okay, so meningomyelocele, again I am repeating, meningomyelocele, yes, both meningeal membrane and nerve root protruded, and myelocele where only, sorry, meningocele where only meningeal membrane is protruded. So how we have to identify, sir? So how we have to identify means we are having one test, that is the trans illuminate test. Okay, that is what we call the trans-eliminate test. So what we will do in the trans-eliminate cyst? Okay, so in the trans-eliminate cyst, it is very basic. Okay, consider this is the spinal column. Okay, this is the meningocele, which is the protruded. Okay, so this is the meningocele, which is protruded. So only meningeal membrane is there. Okay, with CSF means I am putting the torch from this side. Okay, so I am putting the torch from this end. Okay, so the light will pass us to this side. Okay, the light will pass us to this side, means inside only fluid is there. Okay, inside only fluid is there. Okay, so inside only fluid is there, no any nerve root is there. Okay, means that's the positive trans-eliminate thrust, means the light will pass us this sheet. Okay, this seal. Okay, so or we can say this cyst, so the light will passing means that is a yes positive trans-eliminate test, means only meningeal membrane and meningeal membrane and CSF is protruded. Along with this one, the spinal nerve root also protruded, means yes, here it will be the spinal nerves, so the light will not pass us this side. So this is what we call as in the absent trans-eliminate test, that indicating the mylo-meningocele. So the trans-eliminate test it will helps to yes, that is the trans-eliminate test. It will help to differentiate between the meningocele and myelomeningocele. So okay, important one. Okay, this is the most important one. Hope the concept is clear, bachcho. Yes, so we have dealt everything and each and everything related to the our meningocele, myelomeningocele. Yes, spina bifida occulta, spina bifida cystica. Okay, anencephaly. Yes, the basic definitions we have studied already. Okay, so clear, bachcho. Yes, yes. So here, but what I told in the spina bifida, the CSF also leaks in the amniotic fluid. The CSF leaks in the amniotic fluid. So that again there is increase in the amount of the amniotic fluid. So this is also leads to the yes polyhydramnios. So option C is also not answer. Multiple pregnancy. Okay, in two twins urinates more, increased amniotic fluid. Polyhydramnios, maternal diabetes, increased urine output by the fetus. Polyhydramnios, spina bifida, leak of the CSF in the amniotic cavity, increased amniotic fluid. So again polyhydramnios, esophageal atresia. So this is the question they have asked in your Norcet. So what happens? What happens in order to maintain the amniotic fluid balance? In order to maintain the amniotic fluid balance, so consider this is the amniotic fluid cavity. So amniotic fluid cavity, it is containing the amniotic fluid completely. It is filled with the amniotic fluid. Okay. So inside the amniotic fluid, the fetus is there. The fetus is there. Okay. So this fetus, it will swallow this amniotic fluid and it will urinate the amniotic fluid. Okay. It will swallow the amniotic fluid and it will urinate the amniotic fluid. So this is how it maintains the balance of the amniotic fluid. It maintains the balance of amniotic fluid. Okay. It maintains the balance of amniotic fluid. How means it swallows the amniotic fluid. Okay. So swallow will be there plus urine will be there. Okay. It swallows the amniotic fluid and it will urinate the amniotic fluid. Okay. So this is how it maintains the balance of the amniotic fluid in case of the any atresia. What is the atresia? That is the yes, atresia is the this is the normal continuity of the our organ. So if there is any closure in the continuity of the organ, that is what we call as the atresia. Atresia means there is close of the normal body duct. That is what we call as the atresia. Okay. Yes, there is two word it will comes. Okay, there is the stenosis and atresia. Stenosis means this is the normal vessel, or we can say the normal duct. If it is getting narrow means that is what we call the stenosis. Okay, so if it is completely congenitally closed means that is what we call the atresia. Okay, that is what we call the atresia. So as I told, in order to maintain the balance between the amniotic fluid and uh, in order to maintain the balance in the amniotic fluid, the patient will swallow. Okay, so this is the mouth, this is the esophagus. Okay, so here it is the yes or beautiful stomach. So this is the duodenum. What happened here? The esophageal atresia happened here. Okay. So esophageal atresia means this particular esophagus got closed congenitally. So means if the fetus is swallowing inside means it will not able to swallow. So the fluid keeps on remains accumulating in the yes in the amniotic fluid cavity only. So that will leads to again increased fluid, that is called as the polyhydro Amnios. Okay, so this is again called as the polyhydramnios. So very important you have to keep in the mind. So in the renal agenesis, no urine, decreased no urine by the fetus, decreased amniotic fluid, oligohydramnios. In esophageal atresia, again in the duodenal atresia means the duodenum will get congenitally blocked like this. Okay, so there is no connection between the two duodenum. Okay, so this is the duodenal atresia. Okay, in the esophageal atresia and duodenal atresia, again it will be stoppage in the swallow. The amniotic fluid keep on accumulating outside the fetus, means in the amniotic cavity. So that may lead to the polyhydramnios. Okay, so hope the concept is clear. Two things you have to remember. Okay, in the yes, polyhydramnios, the main reason is esophageal atresia or the duodenal atresia. For the oligohydramnios, the main reason is the yes, very importantly how to know, that is the renal agenesis. Hope that today's concept what we have studied will be the very much helpful for you all. Okay, so this is the specialty of the master nursing classes, holding the one word, discussing in detail. Okay, discussing the all possible questions and terminating the questions. Okay, so this is how the integrated study, this is how the study with comparison, it will makes you people to remember for the long period of the time. Okay, so that will helps in the exams when you will be sitting in front of your computers while giving the yes computer based test. Okay, so the words given by the Nagraj sir will be completely coming in your mind. Okay, it will be keeps on eliminating the option and it will be showing you that is the gold option. The gold option is, what is the gold option? Yes, there are four options. Among the four options, the correct option is the gold option. Okay, is that clear, bachcho? So it always the master nursing classes is trying to show you a gold option by giving the knowledge and concept. Okay, this is how the actually process of selection happens. Okay, bacho, if you found any power in the content, so don't forget to hit the like button. Okay, if you new to the our MNC family, so do join to the our telegram group. The link is there in the description box. That will help you to yes gain the much more knowledge for your upcoming any kind of the nursing recruitments. Okay, so we'll meet again in the next class. Stay motivated, stay connected with the master nursing classes. We'll again मीट इन द नेक्स्ट क्लास. तब तक के लिए जय हिंद, जय भारत, नमस्कार.